Welcome to the LDN radio show, brought to you by the LDN Research Trust. I'm your host, Linda Elsiegood. I have an exciting lineup of guest speakers who are LDN experts in their field. We will be discussing low-dose naltrexone and its many uses in autoimmune diseases, cancers, etc. Thank you for joining us. This show is sponsored by Pharmacists Solutions, located in Michigan, who are licensed and can ship to 35 states. They specialise in pain management, support patients and providers in the use of LDN, bioidentical hormones, topical pain gels, sublingual tablets, veterinary compounding, and many unique proprietary dose forms. Visit pharmacysolutionsonline.com or call the Patient Success Team on 877-797-6567. Today my guest is pharmacist Dr Dr Swidan from the United States. Thank you for joining us today, Sahar.
Thank you. It's always a pleasure to speak to you.
You too. And as I say, it's been far too long. Could you tell our listeners about yourself? You know, what made you decide to get into medicine? You know, what was the drive behind it?
Well, I think that's an easy one. Ever since I was a baby probably, or a little child, I always remembered I always wanted to be in the medical field and in medicine. And I always loved helping people and helping people feel better per se on multiple levels. So I think that was easy and basically my destiny from the minute I was born. And then I actually took the MCATs and I was going to medical school, was accepted into medical school. And I met a colleague of mine who said, "Oh, you need to look at pharmacy. It's really interesting. A huge variety in it, different, career paths and things like that." And I always tease to this day, I think the admission counselor drugged me or something, because literally I did a 180-degree turn. I went to pharmacy school. I was accepted in pharmacy school, and I went to pharmacy school and dropped out of medical school per se. But anyways, regardless, it's been a great, rewarding career. I had the pleasure. So I went to school at the University of Michigan and graduated with my Doctor of Pharmacy degree from the University of Michigan. And I always loved teaching in academia and research. I've always been fascinated with that. So I stayed and continued to do a postdoctoral fellowship for 3 years in gastroenterology and biopharmaceutics. And during that world, my professor and my advisor basically fell in love with a French man, moved to Europe, and so we were doing a lot of clinical trials. So I had the pleasure of traveling to Europe a lot, to Germany and France and such, to work with her on these projects. And that's where, honestly, I was first introduced to what I would call functional lifestyle medicine. They've used, a lot more lifestyle functional medicine, a lot of nutraceutical supplements and vitamins, which are much more regulated in Europe, as you guys know, than really they were here. And that's really what I kind of learned, the other side of treatment. And I've just since then became really fascinated with it and took really a career path in pain management and neurology, but definitely with a functional medicine approach to it and a holistic approach to it.
Mm-hmm. So how would you say LDN has played a part in your career path?
So, LDN and many other tools that I honestly you learn along the way. I have the pleasure. I lecture and gab all over the world, as I always say. So I always have the pleasure of lecturing with the most brilliant brainiacy people, I call them, around the world. And you learn a lot of these neat and unique treatment tricks from them and learning. So learned a lot, like I said, in Europe, nutraceutical functional medicine, the gut association and microbiome and probiotics. I learned that 25 years ago, literally from Europe, because as you guys know, you guys have them at the checkout counter at every counter there. And that's when I first like, hey, what is this Yokult stuff? And you learn about, the role of microbiome and pain and inflammation and in modulating the serotonergic system and brain health and gut health and all that good stuff. And so, I first really learned about LDN when I was researching Dr. Bahari's work, because like I mentioned, I did a lot of pain management and neurology, and I published a lot in that area, did a lot of research in that area. And so sometimes, we're really stuck with some of our really more difficult patients. They come to us on huge amounts of opioids. And so I'm always like, I was always researching for out of the box thinking and out of the box treatment modalities. And that's really what I ran across, initially Dr. Bahari's work. And I'm like, and I knew of naltrexone, obviously, because of my world, pain world, if you will. So I've always knew about high dose naltrexone. And I'm like, hey, what is this low dose naltrexone? I'm like, well, that doesn't exist. So who's doing that? And then obviously, and we do a lot of compounding, and I own a compounding pharmacy. And I'm like, oh, that's got to be a compounding treatment because it's low dose. And so when we, and that's when I really started to come out along the research, and I started incorporating that into my teaching around the world, because it was definitely one of the modalities I was teaching providers about low dose naltrexone and the inflammatory modulation. And I always tease, the more and more I learned about this type of medicine, I tease our colleagues and say, now we really have one medical specialty. And I just did a webinar and I termed it inflammatology, the only medical specialty, right? Because we're really finding out that basically inflammation is the crux of all disease almost, heart disease and high blood pressure and diabetes and cancer and autoimmune illness and neurodegenerative disorders and psychiatry, even now with depression and refractory depression and so on. So that's really when I came across Dr. Bahari's work in the inflammatory modulation. And really I was very lucky and privileged to work with Dr. Rosen. And we published some data literally probably 18 years ago now, where we showed that people with chronic pain, they had elevation in TNF levels in the cerebrospinal fluid, but their TNF level systemically was normal. So back then, even 18 years ago, we documented local neuroinflammation in patients with chronic pain. And I said, oh my God, this will be a phenomenal treatment for them because it modulates, obviously, the immune system, and I'm sure it does it in the brain too. And that's really when I started to kind of tripped upon it. Definitely, we started using it in our patients to see the clinical effect, and started teaching colleagues about it too.
Mm-hmm. And what would you say, talking to all these people around the world, that the outcomes from prescribers that are using LDN?
So definitely, and I don't think anything works 100%, obviously, in anybody. I think what's neat about our functional medicine colleagues and the people that are looking at whole body medicine and physiologically based medicine, as I'm talking about that, I think, all the other treatment modalities that they kind of embody and educate and have patients do in addition to LDN, we get phenomenal results. For example, and it was my friend, a colleague, he's a spine orthopod, orthopedic doc. And he's like, I'm almost going to cry. Cause I said, well, let's do this. Let's do that. Let's try this. And definitely I would try LDN. And he's like, I'm going to cry. Cause this big burly fireman, whatever, who's been in pain, had to quit his job, all that stuff. And he sent me this text. He's like, oh my God, this has been the missing link, because we did a lot of other stuff, from optimizing, diet to gut health, to decreasing inflammation, to optimizing neuroendocrine stuff, as especially in opioid patients, that neuroendocrine system is very deranged, and so we did a lot of all that good stuff that typically gets the patients, maybe 80, 90% better sometimes. And then we said, hey, I think let's see if we can just really realign his immune system now. So we did neuro, we did endocrine, and let's see if we can do immune, resetting now. And we tried that on him, and it was funny because he came in, hugging and crying, to the doctor, this big burly guy. He's like, oh my God, this was absolutely the missing link. And now I'm 100%. So we definitely see these home runs, all the time. So and I think it's definitely the success rate is much higher when we embody a full body treatment, physiological medicine. I think sometimes what I tend to hear is like, well, it didn't work, and it didn't help me, and the LDN failures per se. But, we always tell doctors and patients or providers, it's hard to get a home run with LDN alone if there's so many things that are going against it to work. If everybody's still drinking 7 Diet Cokes a day, eating all, white and sugar and all that stuff, smoking, and gut derangement and dysbiosis and all that stuff that we know really deranges the body, it's hard to work against that tsunami per se,
Yes.
and increase inflammation, where when we embody functional medicine approach, fix the other systems, LDN in general has a very high success rate.
Mm-hmm. I mean, there are some people who are lucky enough not to have to do anything else alongside LDN, but they must be the people that do not have any other issues. But if you are eating incorrectly and you're not getting all the nutrients or having supplements that you need, etc., then the LDN isn't going to work, as you say. And there are some people who contact me after a month of being on LDN and say, well, I might as well stop. It's not doing anything for me. And It's not a magic pill, is it, where it's just going to go, hey, presto, and you feel fine.
Right. Well, we wish, right?
Yes.
But exactly. But that's what I mean, what we tend to find in those failures. And you're right, we get these lucky stories, where like, oh my God, my life is 1,000%. And in those patients, I tend to see like they were kind of on the right track, if you will. And this was really the missing link, if you will. And it's like, boom, and boy, does it reset their life, right? And that's why I think this field of medicine is so rewarding to all of us. We get addicted to it, per se. But absolutely, what I find is like when these people go exactly like you said, well, it didn't work. And I said, well, first of all, you want to give it at least 3 good to 6 month trial, right? Because, it depends, and I always remind patients, well, you've been sick for 20 years. We're not going to reset you in 1 month. You know what I mean? And so, and sometimes I think it's expectation of patients, like you're right, because, they want just that magic pill, hit reset, and everything goes away. But definitely you get those magical stories sometimes. But what we find always is if it's part of a logical treatment plan, even those failures literally turn into positives almost 95% of the time.
Mm-hmm. Yes, I mean, that is what we find. And some people say that they have sleep problems or vivid dreams, and many doctors get them to take the LDN in the morning, which stops that problem. Some might have some gut issues initially, but, you can lower the dose, titrate it up slowly. And honestly, I think I have in 14 years only known maybe a dozen people who couldn't tolerate it for some reason or another. Everybody else, just by altering the dose, lowering the dose, increasing it very gradually, have got used to LDN. I mean, have you heard of many people who, can't tolerate it?
Honestly, rare. Really, and like you said, sometimes we'll have people like go, I felt like I was more jittery or wired, or the vivid dreams that you sometimes hear also. And exactly, switching it to daytime usually definitely really takes care of that, and the other thing, or, taking it in the morning, or just definitely starting much lower. Like, right now, and I think that's a new field, what I'm calling, or what we're calling, I think, us and some colleagues, ultra low dose naltrexone, right?
Mm.
So like what we're beginning to use, like I just had a cancer patient who's a doctor actually, and non-believer in this world or whatever. And so I've been like for a year begging them, like, try this, try that, look at the data, and all this stuff. But so by the time he's like really sick, almost on the deathbed, it comes to me, of course, they're on a dilaudid pump now and lots of opioids and stuff. And I'm like, okay, let's just even do ultra lows, ultra low dose naltrexone. We started him literally like at 0.1 milligram, and we're slowly bringing it up. But it's very interesting, and I think that's another world that we need to start studying more. But even sometimes at much lower doses like that, and we tend to do that in our patients on some opioids, obviously, because we don't want to put them through withdrawal, and we do a lot of pain management. But we still get home runs, if you will, even on those low doses. So, and that's how we learned about that, honestly, was the patients that, oh my God, I can't tolerate this, or it wired me, or I couldn't sleep, or I had vivid dreams. And we're like, okay, well, let's start lower. And sometimes even like we would do 0.5 milligram, and they're like, it's still too much, or the opioid people. And we did like 0.1, and we slowly titrated. And it's like literally at that low dose, sometimes it literally turned people's lives around. So it's interesting, excuse me, that even at these low doses, it can modulate. But and I think the point is, as far as tolerability, it's literally one of the most tolerated treatments, honestly, that we use, because it's fairly benign at the low dose. And like you said, you mainly get those vivid dreams, or sometimes you'll hear from patients they're too wired. And I said, no, you're just wired backwards, because this is supposed to come. And so, rarely we do have that in medicine, where people have paradoxical reactions.
Mm-hmm. But it's amazing, isn't it? If there is a condition where there is an autoimmune component, a pain element to the condition, LDN has a good chance of helping that patient.
Yes. Yeah, and you were cutting off. There was a little bit of communication, but absolutely, I think it tends to work. The interesting part too, and I think that's the next world of science of LDN. It's very interesting, but we have like certain patient subtypes that we're calling, because we use it tons clinically, where lower doses seem to work better for them. For example, the Lyme disease and the biotoxin patient, for whatever reason, 1.5 milligram is too low, 4.5 milligrams is too high, and most of them do so much better at the 2 to 3 milligrams. And it's very interesting. Like literally, if I see a 3 milligram or a 2 milligram dose on a patient, I could almost tell you, oh, you're a biotoxin Lyme disease patient. And it's very interesting. And actually, my colleague that we use it a lot for Lyme and biotoxin, I told him we really should publish that, because it's very interesting. There's so much that I think we need to correlate between pain genomics, immunogenomics, and that kind of stuff. And I think there is, in the dreaded HLA subtyping, that we kind of, that term that everybody coined now in people with biotoxin illness and Lyme disease, but probably in any other immune system, they're just the kind that you're going to trip their immune system easier, per se. But yeah, it's very interesting. We do see these nuances clinically in patients, and I think it'll be really cool to do like large cohort studies to see, or epidemiological studies to see, hey, what's the happy dose for the patient type? Because we definitely see biotoxin Lyme disease. And even just very interesting, yesterday, a colleague of mine, he wants to use it for his son, and he says, hey, this is what I'm thinking. He goes, I'm going to give him 1.5 milligrams of LDN in the morning, 3 milligram at noonish, or, and then, 3 milligrams at bedtime. And I said, well, why are you starting and using such high dose naltrexone? Because, most of the clinical trials were done obviously with lower dosing. And he says, I don't know what it is because he's got like neuroinflammation from Lyme, developed a lot of psychiatric, manifestations and that kind of things from neuroinflammation. And he says because immediately when he took a 1.5 milligram dose by mistake in the morning, and he goes, it immediately stopped his twitches. And then he started again. In the middle of the day, I gave him 3 milligrams, and that stopped his twitches. So now I have him on TID dosing for mainly twitches and neuropsychiatric stuff. And I'm like, wow, how fascinating, And that's what I mean. This is all the stuff that I think we honestly need to study more, and see, hey, what's the clinical implication or value there?
I mean, there are quite a few doctors now that will prescribe double dosing to patients who have chronic fatigue syndrome, because the patients found by taking the LDN in the morning, it gave them more of a buzz and energy boost. So by taking it again at night, they would take it at night and they would have an energy boost in the morning, but then they seemed to flag, so that they then took it in the morning as well, night and morning, and it gave them far more energy than just taking it once a day.
Yeah, so that's what I mean, because as most of the initial trials, it was, the once dosing at bedtime, pretty limited to the 4 to 7-ish milligram range, That's what I mean. So I think it'll be interesting. Is there value? Because, Dr. Bahari's work was always mainly at night and all that stuff, and lactose-free and all that stuff. But yeah, so I think it'll be interesting to see, is BID or TID dosing better? Is it better to split 1.5 milligram TID, let's say, and then you stay in the low dose range, if you will, and, you're still at the 4.5-ish, but it's split up, TID, because we know it also has a short half-life, at least the parent half-life, and the metabolite is a bit longer, but a little bit weaker. So,
but most of these that I was saying about with chronic fatigue syndrome, if they were okay on 3 milligrams or 4.5, whatever dose suited them best, the doctor would then replicate that. So they were having that dose twice a day. They weren't halving it. So if they took 3 in the morning, they took 3 at night, 4.5. But it would seem that, everybody's an individual and everybody's condition is different. Man, woman, tall, short, heavy. But it would seem that it's what dose suits you best. It's not the case of the higher the dose, the better the benefits. Some people do genuinely feel better on, say, 2 milligrams, and that once they increase their dose, they don't feel as well. And once they drop back, they feel a lot better.
Yeah, exactly. And that's the ones we see, like I said, in those patients, like, the Lyme biotoxin ones, for whatever reason, a lot of time, we'll push them the usual 1.5 and then 3 and then 4.5. And then a lot of them will say, God, I don't feel good. I'm going back. And then they go back to the 3 milligram and they feel great again.
And it's strange, isn't it? Because some people will say to me, how do I know if the dose is too high? What do you mean by you don't feel as good?
Yeah,
but
they know.
Even that varies from patient to patient as, how they feel. And it's very hard to explain. You will know, but how will I know? Just believe me, you will know.
Yeah, exactly. And that's why we tell them, like, you're just going to feel as bad as we did before you started it,
And then you have some people say, for whatever reason, financial or maybe having surgery or something, and they want to stop LDN, and they ask, do I have to taper it off? Can I just stop? But I must admit, most people who have stopped taking LDN have forgotten how bad they were before they started. And 9 out of 10 restart because they then realise the benefits that they were getting from LDN.
Yeah, no, exactly. And I think a lot of times, well, because it's all relative, right? And then or they feel better, but not as good as, as they did as baseline per se. And then they're like, okay, well, I feel like 70% better, but like, I really want to feel 100% better. And stuff. So you definitely get a lot of that too. But you're right. A lot of times when they go, well, it's not doing anything. And that goes with some other treatments too, and then they stop it and they're like, oh my God, that was doing something. And then they go back on it. Exactly.
It's amazing. So if people would like to contact you, how would they do so?
Yeah. So if they have any questions or, email is probably the best thing because I travel tons around, speaking and lecturing. I'm writing a book right now on opioid-free pain management. So definitely I'm going to be doing, obviously, a chapter on low-dose naltrexone and the benefits of it, because it's definitely another tool in the shed for, especially with the opioid crisis that's in the U.S., but really worldwide, obviously. So we're really trying to teach providers other methodology for pain management besides, the NSAIDs and opioids. So, email, they're welcome to email me at swidan@umich.edu. And I also have a website, sahar.world. So that's easy. So you can also find ways to contact me there and see some of the unique teachings and publications and things like that I'm working on. So yeah, sahar.world or swidan@umich.edu.
So just very briefly, we've just got literally 2 minutes left. Tell us a bit more about your new book that you're writing.
So it's really, I look at it as a humanitarian effort. So I'm writing, so I'm going to be the editor with a colleague of mine, Dr. Matt Bennett. We're going to be the editors for this book, Opioid-Free Pain Management. And our goal is to really find some of the best outside of the box thinkers in pain management and have them write chapters on some of the different unique ways that they're using in their treatment algorithms for pain management besides opiates. So I'll be writing a few chapters, so will Dr. Bennett, but we really want to also give the readership a flavor of all the unique things that's also some of our colleagues are doing around the country to really enhance and hopefully abolish chronic pain, especially non-malignant chronic pain, and teach them other ways to do this, because we've known for many years that really opioids are not good treatments for chronic non-malignant pain, and we really need to teach them, physiologically based, holistic based functional pain management to really get the patients definitely most critically better, feeling better, but also to stop some of the opioid issues that we have around the world, really, not just the U.S.
Yes.
So this is kind of like our humanitarian effort to the world, and pain management is where kind of viewing it and calling it.
Mm-hmm. Well, that's amazing, because a lot of the opioid medications, of course, are addictive, and are not good for your organs either, are they?
No, absolutely. Especially the ones with the, Tylenol and the liver issues. Non-steroidals, are hard on your kidneys and gastrointestinal tract and stuff. And you know what? They're great. We need them in certain settings, especially, if your body was just smushed to heck by a semi-trailer or surgical or whatever. So absolutely, opioids are phenomenal because they really decrease pain and stuff, but for short term, right? So,
exactly.
So it's also teaching people appropriate use of these medications. And I think, maybe there's a lot of, fingers we can point, but again, the bottom line is we have to fix it. There's a problem. We have to fix it. But now, our providers, especially here, are very afraid of opioids and prescribing and what to do. But then what do you do with all these chronic pain patients, in fibromyalgia and chronic fatigue and Lyme disease and biotoxin illness and chronic back pain and neurodegenerative disorders and, bad hips, bad knees, as we get, our population is aging more and more too. So, but, the good news is there's tons of other ways to help patients. And now we just really have to do a huge, massive educational effort from the ground up, if you will, to really teach our colleagues some of these functionally based, physiologically based treatments for pain management.
Well, that's amazing. Well, thank you very much for sharing your experience with us, and good luck with the book. And once the book's published, maybe you'd like to come back and tell us all about your findings and what's in the book.
Yeah, absolutely. We'd love that. And we'd love to, yeah, get it to your readership on the website just because I think it'll be a very invaluable tool for your readership and our colleagues on the LDN Trust, because a lot of times they're also dealing with chronic pain issues, obviously.
Yes. Well, thank you
Yeah,
very much.
absolutely. Always a pleasure. Thank you, Linda.
This show is sponsored by Pharmacists Solutions, located in Michigan, who are licensed and can ship to 35 states. They specialise in pain management, support patients and providers in the use of LDN, bioidentical hormones, topical pain gels, sublingual tablets, veterinary compounding, and many unique proprietary dose forms. Visit pharmacysolutionsonline.com or call the Patient Success Team on 877 797 6567. Any questions or comments you may have, please email me, Linda, Linda, at ldnrt.org. I look forward to hearing from you. Thank you for joining us today. We really appreciated your company. Until next time, stay safe and keep well.